the National Center for Medical Home Implementation. This webinar is the third and final installment in the 2014 How-To webinar series titled Fostering Partnerships and Teamwork in the Pediatric Medical Home. This educational webinar series is presented by the National Center for Medical Home Implementation, a cooperative agreement between the American Academy of Pediatrics and the Maternal and Child Health Bureau. Before our faculty begin, I'd like to inform you of some housekeeping items. The slides will appear in the central window of your screen and will advance automatically. We encourage you to ask questions throughout the presentation using the question box window on the right-hand side of your screen. These questions will be answered at the end of the presentation. If we do not have time to answer your questions during the webinar, we will send you an answer directly via email at a later time. This webinar will be recorded and archived on the National Center for Medical Home Implementation website approximately 1 week after this presentation. After the webinar, you will also receive an email with a link to the webinar evaluation. We encourage you to complete this evaluation so that we can continue to improve the content and manner of our presentations in the future. And now I am honored to introduce you to today's moderator and faculty members. Dr. Jennifer Lael is a general pediatrician who has practiced in a Level 3 NCQA recognized patient-centered medical home for over 30 years. She's a member of our National Center for Medical Home Implementation Project Advisory Committee, and she currently serves as the Vice President for Chronic Care Systems at the Anderson Center at Cincinnati Children's Hospital Medical Center. Dr. Christina Pelaez is originally from Colombia and is now a practicing pediatrician and director of the medical home in the University of South Florida. She is a founding member of the Florida Chipra Medical Home Demonstration Project and serves as an expert group member for the same. Tim Lane is an advocate for family-centered care in pediatric practice and an active member of the University of South Florida Pediatric Parent Advisory Group. He works very closely with Dr. Pelaez and is a parent of a child with special health care needs. Susan Sommer is the Clinical Director of the Community Asthma Initiative, which is a Healthy Tomorrows Partnership for Children program at the Boston Children's Hospital. Shanice Brown is an active member of the Boston Children's Hospital Community Asthma Initiative Parent Advisory Board. Shanice and her family are also members of the Boston Children's Hospital Primary Care Center Medical Home. The presenters have no financial or conflict of interest disclosures to announce. And with that, I will hand it over to Dr. Jennifer Lael.
Good afternoon, everyone. I guess for some folks it may be morning still. We have some objectives for this webinar that we hope will meet your needs. Our first objective today is to be able to define the term Family Advisory Group and to explain how that may be an effective tool in the family-centered medical home approach to care. We'd also like for our participants to be able to articulate strategies to prepare and implement family advisory groups within a practice, and we will provide you with examples of successful advisory groups so that you could gather ideas from them. Next slide, please. So I want to start off by establishing what we're talking about with the pediatric patient-centered medical home. We know that the American Academy has been talking about the medical home since the 1980s, but this has been a growing concept that is now accepted by adults, by family practitioners, and so we are very proud as pediatricians that we sort of started this conversation. We like to look in pediatrics particularly at the family as a critical component of outcome, because we know that if our families cannot deliver the care that their child needs, then the outcome will not be improved. So we know that a pediatric medical home uses a team-based approach to care, which does include families as a critical player. The pediatric medical home works with families to not only improve the outcome for illness, but to enhance the child's general well-being and health. So it makes perfect sense that to ask our consumers or our patients or the people who we are serving to give us ideas about how our patient or family-centered medical home should operate. And having a family advisory group is only one way that we can increase that partnership between parents and caregivers and the practice team and the community to be able to optimize a child's outcome. We know that when we can have family advisory groups, they give us the particular perspective of the parent and family that we as physicians or clinicians or nurses or staff may completely miss. So one of the things that we know that is critical in a patient-centered medical home is having your senior leaders and your team dedicated to the fact that families are equal players and are at the table with you in your systems improvement. Let's have the next slide, please. So we know that there are joint principles of patient and family-centered care, and we know there are core concepts in that. The concept of a family advisory group is just one way to implement these core concepts and to improve our family-centered care. So before we even talk about building a family advisory group, we have to be sure that in our interactions with our families and patients that we are interacting with them in a way that is dignified and respectful, that we share information with them in an unbiased way. I think we lost our slide there. We share information with them in an unbiased way that helps them share decision-making with us, that helps them let us know what will work for their child and their family, that we are encouraging their participation in care, again, the shared decision-making concept, and that we are collaborating with them and we'll come back to say, how can we do better? What are the places we need to improve? This is not just about electronic connections, it's about how we behave, our attitudes toward one another. So when we think about things like patient portals and scheduling and all those sorts of things, that's a sort of easy approach to saying, yes, our families are involved, but actually treating the families with on-par respect and having them at the table is certainly a big piece of that. Let's have the next slide, please. So when we define a family advisory group, which I will tell you I think is a pretty high-level performance for our patient-centered medical homes, one of the things that we have to talk about is the fact that as much as it makes absolute obvious sense to have families advise us in practice, there is not a lot of literature in the pediatric or even in the adult literature that describes in an explicit way what the impact is of family advisory groups. We know that there is a large evidence base about the impact of patient and family-centered care on outcomes, on quality, and on cost, but family advisory groups are a new enough concept that we don't have a lot of literature on them, once again, although it seems like a perfectly obvious thing to do, and I think all of us on this call strongly support it. So a family advisory group involves patients and sometimes patients, young adults, particularly in our situation, parents and caregivers who are joining with the practice and members of the practice team to identify what things are important, what things need to be addressed, what things need to be changed, and what things need to be strengthened. And we know that when we have a family advisory group, one of the things that we have to assume is that parents are the experts in their child's care. That is a founding principle. The members could be a young person, they can be a parent, they can be a grandparent who is a primary care provider for a child, but we must have team members, not just physicians, but team members across our team to help us hear what the families have to say. I'm sure our families can tell us that the ability to have a conversation about an appointment or to check in is equally as important as some of the other steps that will occur in their appointment. And so having members of the practice team who are involved in those components of care are equally important. The family advisory group needs to meet with some regularity. It may not be every week, but certainly to have an expectation that you will reconvene again. It's a great way to look and say, what are the things we're doing great? Let's celebrate that, but what are the things that we could pump up a little bit, do a little better? Next slide, please. So we know that when we do, if we assume that we can have a family advisory group, we know that that gives an opportunity to hear the voice of our families, to share experiences, to identify things that absolutely need to be addressed. When I was in practice, our families told us that checking out after you've had a child who received a shot or had something unpleasant done was untenable, and that all of that work needed to be done beforehand, and that was a big eye-opener for those of us on the clinical side of things. Our families can help us create educational materials and tools, they can help us know what we ought to be measuring and how to evaluate things that we are working on improving. And certainly, we know that our families are critical to the health outcomes of our children. They help us know how things get done. Remember asking parents which physical therapist works best with your child. And so our families are huge resources across many planes. We also like to understand that by having a family advisory group, we're making a statement that our parents and caregivers are critical parts of our team, and we are empowering them to give us input and to work with us in a shared decision-making way. So let's have our next slide here. One of the things that we know is that you don't just say, wow, let's start a family advisory group. There are things that you have to have in place before you can do that if you want it to be successful. Now, I would go back, and we don't have to turn the slides back, but I would go back to the slide about our attitudes about interactions with families. I think that that is a definite prerequisite. We have to be absolutely certain that we are clear that our families' voices are things that we can hear, we want to hear in a dignified and respectful way. So when we start to talk about building a family advisory group, we do have to gain buy-in, not only from our colleagues, but from our leadership, from the people who fund things in the practice, and really it becomes a phased implementation based on that foundation of how your interactions directly with the families happen. So your practice may want to look at the fundamentals about how they ask for family input now. Do you have a survey? Do you ask parents informally? How are you doing the decision-making around the plan of care for the child? Is it orders that are handed down? Is it a collaborative process where the parent says, gee, this will work for me, or I can do that, or I can not do that? Those are the kind of things that before you even start a family advisory group, you have to be sure that those other fundamentals are in place. The other thing you may want to look at is your practice's quality improvement capacity. If you say, gee, I'm going to ask these parents to tell us what we're doing right or wrong or what we could do better, you have to also be dedicated to making the changes that are identified, or at least addressing them. So raising concerns that you can't or will not address is frustrating. So we have to be sure that we have the ability to act upon the concerns that are raised. It's important to make sure that you have processes and mechanisms in place to be able to make change, and that you have any financial or budgetary issues ironed out about your family advisory group. And I do hope our folks today will talk about whether or not families are given a stipend for their participation, are they reimbursed for gas, those sorts of things. So if I can have the next slide, please. One thing I want us to think about, it seems perfectly, absolutely reasonable to say, gee, let's ask our families, but we also have to think about potential risks or benefits. We need to think about how the family interacts with us, whether or not it will change the way we deliver our care, whether or not a family will feel at risk about bringing up a topic that may be an unpleasant topic. So we have to think about those things and make sure that we've considered that and that we're attitudinally ready before we start a family advisory group. We have to make sure we know the structure of the group and how it would work, who would lead the discussions, who would keep the group on time, who will establish the meetings. And those kind of things are all important before you start any initiative, but certainly with our families it's very important as well. So whoever is the leader of the group has to be able to set an agenda. I think all of us know that a meeting without an agenda is a frustration. So we have to be able to set an agenda, communicate with people, make sure that if a meeting is canceled that everyone knows about that, and be able to work with the patients and families and have time to actually do this work. We're certainly all busy folks. If you have a facilitator that you've selected, then you want to decide which are the parents who you think will be able to give the most to your group and from whom you will be able to learn the most. And so parents who have been proactive in their children's care, youth who are ready to talk about their care processes and who have learned about their care, and parents who've been in the practice for a while are usually good choices. We know that all of us, when we join a group, have sometimes our own personal agenda, and those really do have to be sort of left at the door at these sort of meetings, such that we can think widely about all sorts of patients and not just the things that matter to us particularly. And then finally, we think it's really important to have a diverse slice across your population so that many, many families can be represented in your family advisory group's thoughts. Could we have the next slide, please? So if you start a family advisory group, clearly you have to figure out who is going to be part of the team. You have to set up a schedule. Most of our groups have a time limit to their meetings, and they have picked out how often they will meet, whether that's once a month, once a quarter, once every week. And then you can decide after you see how things work whether or not the meetings need to be more or less often. Consideration of family schedules and the ability to Skype into a meeting, the ability to call into a meeting, or to happen at a time when someone has child care or is after their work are important things to consider. It's also important to know that you want to keep minutes of these meetings. You want to have a communication plan so that the other people in your practice and that other families would know what was discussed. The HIPAA security issues, you'll need to consider whether or not your family member has to have a HIPAA business agreement in order to be able to participate in this, particularly if there is any private health information that's going to be shared either on purpose or accidentally in those meetings. And then certainly it's helpful to have goals and expectations for the meeting so that you know what you want to accomplish that day and then can be able to create your deliverables. So next slide, please. And with that, I do want to hear exactly what Dr. Pelaez and Mr. Lane in South Florida have been doing, because I think they can give us some real details.
Yes, hello. Okay, my name is Christina Pelaez, and what I would like to do today is I want to walk you through what our experience was creating the Parent Advisory Council. Next slide, please. All right, so here we have the picture of our first meeting that we had with our USF Parent Advisory Council, which we were very proud to have. So just to give a little bit of background of what type of practice we have an academic practice with we have 3 sites. One has residents, and then the other one is a shared practice with med peds, and then we have type of like a private pediatric clinic. So we recruit patients actually from all the specialists. We actually included pulmonary, cardiology, and then nephrology. We wanted to have like a broad type of patients, you know, to be part of this group. For the general pediatrics, we are a 30,000 radius patient, and 80% of our patients are Medicaid. Which 45% are African American. We have 35% of them white, and then 10% Latino, and then the rest are minorities, especially people from Haiti and Asian patients. The reason we started this was basically because of the importance to create a high-quality functional medical home, and also part of my involvement with the AAP and the CHIFRA project. So next slide, please. So you know, in this slide we have like the practice view, why we would like the advisory council, and then when you hear from our fabulous parent, you're gonna hear his perspective view. So I feel like there is 4 very important critical points when you develop this type of group. You have the motivation. So what does motivate our practice? It's actually to improve the parents' partnership as a critical point of having a high functional medical home. Our role is to guide them and educate them, because like Dr. Lyle said, you know, they are the experts of the care of their children. We only see them for, you know, 15 to 30 minutes in our visits, but they heavily, you know, 99% of the time. So we need to hear them and collaborate with them on the care of their family. The benefits from these will be to increase the quality of our care and also the satisfaction on their part. Another very important point is, you know, to make sure that they feel that we actually hear them. Sometimes we just forget that. And then the future is because now, you know, we have the trend that we change to family-centered care, so we want to make sure that we are ready for the parents. and we want to work as a team. Next slide, please. So we actually were very fortunate to have here at the USF the person who's the founder and manager of the Florida Hats, which is the Transition to Adulthood coalition. So she's also an expert creating these parent advisory councils. So we created a PDSA cycle and went through the recruitment for this group. In the past, USF had failed to create a parent advisory council, so I actually have to, lobby to tell them how important this was and how we wanted to have this as part of the medical home. So we basically, the plan was to create the Parent Advisory Council, meet 4 times per year. We wanted to recruit 15 families from all 3 practice sites, and we not only wanted the families, we wanted to recruit general pediatrician specialists, hospitals, social workers, and the nursing staff, because again, this is a team effort. It doesn't help if I just ask the parents. They also need to listen what the parents would like to say. Next slide, please. Okay, so now the do part is we actually, before we start the recruitment, we created this survey. It was on an electronic iPad format, and I did a shorter version of the CAPS. The CAPS is the questionnaire that is nationally recognized to, evaluate the high functionality medical home. And so I would have some data to present to the parents about what was the satisfaction for our care. The recruitment was done in a month basis. We kind of like scratched our heads thinking how we were going to do this. So we actually did it doctor-driven. So it was the doctor would identify the patients that they mostly would, participate in these kinds of activities. And we also wanted to create a steering committee with all the variety of, patients and staff that we would like to do. So we actually had 8 families, 5 providers, 1 nurse, and then we have 1 teen, and then one patient in particular that wanted to participate, because we also have, like I said, we have the family. So we have mom, dad, and then some of the teen, and then maybe like a small child. We also had it too. Next slide, please. Okay, so we have positive results. We went from 0 to 8 families, and then we had a positive feedback. They were all very enthusiastic about, being part of this group. Then one of the things that we noticed is it was difficult to recruit. I mean, we have to do intensive, massive remindings weekly. We've hung like papers around the clinic so people don't forget to recruit the patients. We actually make personal phone calls to all the providers. We also noticed that, that they were either not showing to the meetings either because they couldn't or because the patients got sick. Next slide, please. So, the act, so we thought that, next time that we'll do our recruitment, we won't limit it to the doctors, that we will actually to maybe tap on other parent groups, like if there was any parent initiatives or other coalitions, in the area that we were going to tap to try to recruit more parents that they were actually part of our group. And actually, we have one of the parents that is actually an active member. It doesn't come to USF as a patient, but we also wanted to see what the outside view, from another patient that goes somewhere else, so we could see differences and learn from both experiences. We also wanted to maybe advertise the clinic on the front desk and the bathrooms or in the patient bathrooms so they actually participate and come in. And then maybe just do some web communication on Facebook. Now we're going to have the patient portal so that we can use that in the near future to have that. Next slide, please. Right. So one of the things the Parent Advisory Council they wanted to start a parent blog. They thought that they needed that to share their experience. So actually, one of the parents volunteered to actually manage the blog. But as you know, in the academic centers, everything is very slow. So we do need to have some quality and also HIPAA and some protection to post these and to have like a more interactive. We also they wanted some mentorship from parent to parent, so we're looking at that at this time. Next slide, please. All right, so this is just an example of one of the posters that I have in the waiting room, and we actually had it on all 3 sites, and this is in the waiting room because also when you talk about the medical home, they don't understand what that means. So we thought that educating the parents about what do we mean and what does it mean for them, and every time we have a meeting on the bottom corner that we just will stick like a new time. So that way they knew when the meeting was going to happen. Next slide, please. This is just a sample of one agenda, and I just wanted to put it over there so you know what that means and what type of things we discussed. In the meetings that we had, we have every time like an educational component, so we educate them in something that we think that is important for them, and we ask like on the meeting, what would you like to learn from us, and then we just talk about that in the next meeting. Next slide. All right, now I'm going to hand it to Team Lane.
Thank you, Dr. Pelias. Most of my comments are going to echo Dr. Lales, which is whether you're talking about ongoing care or an advisory council, parents are your voice of customer that you desperately need. In both our groups and our practice, value is placed on our input and expertise of the parents. We carry equal weight amongst the team. And, parents get easily frustrated, especially parents of chronic or complex medical cases, with not being heard in other environments. And certainly we've felt that in the past, that when you're dealing with unfamiliar medical professionals, the doctor at the emergency room or the specialist you haven't seen before, parents often have to elbow in to make sure that they're heard. Sometimes off the cuff, parents are viewed as emotional or ignorant of the medical details. And most parents are neither of those. We're the primary caregivers 90% of the time. We know the signs, we know the strategies, all of those different things. You've got to listen to them, and sometimes you have to pry because parents are not necessarily the most articulate in medical terms. So you have to ask questions and you have to work to get them involved. Next slide, please. So you take a look at our particular motivation to be part of the council. One is to get the best possible care for our own medically complex child. And I think that you'll find that similar in a lot of your parent populations out there. We certainly have a desire to drive positive change for other families with at-risk children. We spend a lot of time in NICUs and PICUs, and you see parents stepping off the curb with a medically complex child, and they're scared to death. And so we've certainly seen that, and we want to find ways to improve that for future parents. And personally, we do a lot of this out of community service and philanthropy. One of our twin boys passed away last year, and so we do a lot in remembrance of him. When you take a look at the roles, and again, when you take a look at your potential population for your parent advisory groups, I know this: if both my wife and I weren't simultaneously involved, we probably would have gotten fired a long time ago because we both have time constraints, as every parent does. So we found personal success with dividing and conquering. So I'll take on certain roles in being a liaison for the patient-centered medical home and doing some grand round presentations. And my wife handles the primary care coordination for our child, and she's very active in the Parent Advisory Council. So whether it's finding a family that can tag team it, if you will, or finding folks that have the time to dedicate it, obviously that's critical to the mission success. Next slide, please. And again, the benefits, certainly driving the best possible care for our child, positive impact for future families. In the future, we certainly look forward to more formal interaction and guidance to both USF as well as the AAP, engagement in the patient portal development, and finding ways to enhance or develop new services for at-risk families. Dr. Pelias, I think you were going to take it from here.
Yes, please, next. Thank you, team. So, as you see, I'm very, very lucky. I have a very active parent, and they're not very hard to find. So just tap into your parents. They know they wanna help. And I will have to say, when team presents with me at Grand Rounds, he make a huge impact, and that's the biggest feedback that I get. And that's what makes the transformation possible. So what does work for us? So this is just some practical tips. Meetings, we try different timings. So, but what has been working the best is the 5:30 to 7:30 p.m. And why? Because they're leaving work. You don't want to stop as a parent. You know that once you stop home, you're never leaving. So you need to catch them before they go home. The offer meeting options. So we have face-to-face, we have webinars, we have conference calls. Definitely incentive work because they do need to pay for childcare or transportation, so make sure that you offer that. Also, places that they know. You don't want them driving around in a place that is unfamiliar to them. So most of the times we have the meetings either like on a center that they know or here in our clinic. Offer food because you're always hungry when you're coming off of work, and then have an educational activity, and then accommodate for the parents. Do not accommodate for you. Okay, next slide. So lessons learned is they need guidance. They need to know what they have to do. So you really need to give them a role. They like to help. Listen to them, listen what they are asking for, and then very important, and that's one of the difficulties that we face right now. I don't have a staff member that is dedicated to follow with the families. So at this time in the past 6 months, we haven't been able to meet because what the parents wanted, we haven't been able to have it in place. And we want to make sure that we are also reliable to them. Their time is valuable, and we don't want to waste their time for what they don't think is interesting for them as well. So so that's one of the things that we haven't met, but we send them an email saying, hey, we're still here, we just haven't met because we need to do what you asked for. And that's pretty much my 5 cents to do. Next slide. All right.
Hi, this is Susan Summer from Boston Children's Hospital Community Asthma Initiative. Good afternoon to everybody. I'd like to give you, next slide please, a little background on both the Community Asthma Initiative and our Family Advisory Board. Next slide. It's a picture of our advisory board. So the Asthma Initiative is a home visiting program that was piloted first in 2005 as a quality improvement initiative in response to community needs assessment that the hospital did around the priority health needs, and asthma was identified as one of the top priorities, and in fact is the #1 admitting diagnosis to children's. So we are under the auspices of our community
benefits department, and have also been able to get some additional grant funding, including Healthy Tomorrow, so thank you very much. And we just want to point out, not a research study, but we do track outcomes, and that's been important to keeping us on focused on the overall goals of the program, and have been very successful in reducing asthma emergency department visit rates among the families we follow, as well as admissions. We provide comprehensive asthma education, case management, and home environmental assessments, both through home visits and then also follow up over the phone. And the demographics of the families that we follow reflect the health disparities that we see around asthma in Boston and other communities in the country. And about 47% of our families are African American and 48% Latino, and 70% are on Medicaid, as well as 95% who live in subsidized housing. Our goal with the Family Advisory Board that was convened a year after the initiation of the program was to get feedback from families who were served through the program, as well as also overall more general feedback from parents who were recommended by primary care providers, primarily through our hospital medical home. Children's has, very large primary care practice, and actually several, both serving younger children as well as adolescents. And so getting feedback on services, input into the program priorities, and learning more from parents about the barriers to good asthma control that they experience, so that we can support them and design our program in a way that's useful. Next slide. Actually, just to back up a second, we are slightly outside of the mold for as compared to the prior presenters, because we're not embedded in the medical home. We serve children from Boston who are seen in our emergency room or admitted for asthma, and about half of the children we see attend primary care clinics within the children's immediate system. But we do also work very closely with the primary care clinics here, and as you'll hear from our parent who was kind enough to join us today, we do have parents who are followed by us, but also by primary care clinic here, as well as specialists and other people within the providers within the children's system. So we initiated the advisory board as I said, a way to get feedback. We have generally, so this was started in around 2006, had meetings 3 to 4 times a year, and with subcommittee meetings as needed when we were working on a particular project or event. We, initially and annually would review the ground rules for the meeting, in particular around confidentiality, and as well as respecting others' opinions and sort of ways to conduct the meeting. We would have an agenda that was set by our team within the Community Asthma Initiative, with input from parents during the previous meeting. We had provided incentives, $25 grocery gift card, free parking, dinner, child care, and we had a lot of kids show up. So in our case, having child care service with a lot of usually 2 child care providers, and including a child life specialist to provide that care was very important to the families who came to our meetings. We did have some diversity of parents in terms of language, primarily Spanish, and did have a couple of different arrangements. We had an interpreter come once or twice, but then switched to the headphones where we could do simultaneous translating during the meeting so that the parents that were more comfortable in Spanish could sort of feel a little more engaged in the meeting. It was challenging. I would say some of the Spanish-speaking parents were certainly more vocal than others, but this was another important aspect. The meetings were initially chaired by the nurse case manager, me, and more recently by a program coordinator through the Community Benefits Office, who had a very nice rapport with families. Does require some administrative support, as was mentioned by Dr. Pelias. We did have an administrative assistant who would send out reminders about meetings, you know, and try and get responses from parents, ordering food, setting up the meeting space, keeping the minutes, all of that stuff. So it is definitely something that you need to sort of be aware of and have capacity for. And then every year we would add some new families since there would be some drop-off from year to year, with also some families that were very consistent over a number of years. Families identified, next slide please, many issues including poor housing conditions, need for more outreach, community education about asthma, a lot of confusion that they had, and they were aware other families had around inhaled steroids. They were very adamant about needing activities geared for children with asthma, especially around exercise, and for the need for better communication with schools, as well as communication between providers within the healthcare system, and between inpatient and outpatient, primary care, and specialists. So that was all feedback that we got from parents. Next slide. We had a number of activities that came out of the advisory board. We, as the Asthma Initiative, presented program outcomes for families so that they would be aware of what we were doing and give feedback on that. The parent education was an important component of meetings as well, and again, addressing parents' ongoing concerns about medications, challenges around adherence, and we also at every meeting shared resources. There was a table that would have community resources, flyers, as well as asthma research opportunities. And we saw parents as ambassadors who would in turn share these resources with others within the community. We did work on some educational materials with the advisory board. We tried to get parents to help create them. That, I think, because of, as I'll mention later, competing demands was challenging, but we would bring a draft and get feedback on that. Thank you. We also were able to, since there were a lot of children, have a focus group among the adolescent children who also often attended the advisory board and would, go off during the meeting and do their homework. And we did get a lot of very helpful information back from them around their understanding of asthma and asthma medications, challenges with adherence, interactions with health care providers that were helpful or unhelpful, and suggestions for an adolescent health website to have a new section on asthma and what kinds of information would be helpful. Next slide. We provided advocacy training for parents and prepared presentations for our CDC site visitor. There were opportunities to attend to speak at City Council and legislative hearings, since there are many, a number of initiatives around housing and reimbursement for the kinds of home visiting services we were providing that were being considered in these various bodies. And we organized very much at the parents' urging to community forums because they felt strongly that people in the community still needed more information, that they weren't getting the kind of asthma information they needed in order to help keep their children's asthma under control. And parents were very involved in those forums, both in the planning as well as presenters. Next slide. So successes and challenges. There was a lot of parent enthusiasm and consistency. We, as is common, I think, for most families, there are a lot of competing demands, and so sometimes there would be a lot of ideas thrown out, but it was sometimes difficult to sort of bring them to fruition because of competing demands on the parts of the families. We did, have a little bit of a challenge in terms of not initially setting a term of time for participation for parents, and there was somewhat a bit of needing new voices that we sort of struggled with at times, but at the same time, the parents who attended were incredibly connected to each other, as well as to the staff from the initiative, and the advisory board definitely served a very important role in terms of support for parents, and it was really like a gathering of friends when people would come to meetings. Next slide. And so now I'd like to introduce Shanice Brown, who will give the parent perspective.
Good afternoon. My name is Shanice Brown. My perspective, the motivation for me joining the Community Asthma Initiative Advisory Board was I was a concerned parent. I wanted to find out all I could and help my son from a parent standpoint, and to see if I can gain insight from other parents regarding my son's sickness. I saw a ton of parents having the same issues as far as things that were going on in the hospital, in their homes, in the school, and joining the advisory board helped me gain more information. We were able to talk amongst each other and maybe, I'd say, help each other out from these standpoints. Next slide. The benefits. the support. There was a ton of support from the staff, the parents, the kids. The kids were able to support other kids. The parents were able to support each other. And I know that Susan said that it wasn't it was a support group rather than an advisory board. That was one of the concerns. However, it was just great. It was great to know that you were able to feel some type of connection with these families. You gained a family. You met families with other issues and concerns just like mine. The only challenge that I can honestly say that I had is that I wasn't able to participate last year because I was in school, and I was able to participate via email with just them sending me the minutes from the meetings. Next slide.
I think this is
I think that's you,
Dr. Leo's slide.
I think this is just wrapping up the end of the Community Asthma Initiative. And then,
can I just add one thing? This is Susan. I don't feel at all that the advisory board was just to clarify very well functioning as an advisory board, and I think over time there was a little bit, as I said, a lack of fresh ideas, but absolutely it was both an advisory board and a support group. So thank you.
Could we have the next slide, please? So thank you. We have some conclusions, and particularly Mr. Brown and, Ms. Brown and Mr. Lane, thank you for your insights. I've made a couple of notes about things that you said so I can store those. Thank you. So what we know is that a family advisory group can be a very effective way to enhance our family-centered approach. There is certainly homework we have to do before we do it, but a family advisory group can be a very sophisticated way to do that. And the benefits of the family advisory group help us learn in a bidirectional way. That is, the family learns more about the practice or about their child's condition or about the medical system, and we certainly learn about the parent perspective about illness and access to the health care. The successful implementation of a family advisory group can improve our ability to enhance the quality of care because we understand better about what our families and our patients need. Next slide, please. There are a list of resources here, all of which I am excited to be able to give to you because they have been helpful to me along the way. From the Picker Institute, which is at the bottom of the slide, I will tell you that, and I can't remember who the speaker was, but she talked about the families as a key determinant in the child's outcome. And that was really a big light bulb for me. The National Initiative for Children's Healthcare Quality has a toolkit. Certainly at the very top, the National Center for Medical Home Implementation is the group who's brought you this webinar. And they have lots and lots and lots of information on everything from co-management agreements to family advisory groups at the National Homes website. Next slide, please. There is a series of videos. I think we're the final one in this group of videos, but you can go back and look at the others, and they've got the links here for you. Next slide. And now I think, Alex, you're going to help us with questions from our listeners.
Correct. Thank you very much, Dr. Lael, and all of our faculty members. We are running a little bit short on time, so I think we're only going to have time for one question, but I want to ensure the audience members that all the other questions that have been submitted will be answered after the webinar. We will collect them and resend them to the faculty and the moderator and email you directly with the answers. But there was one question that was asked, which I think is really important to bring up, and it says that this person that asked this question said that they have encountered significant difficulty in ensuring that parents are heard by the professionals at the table. How would you suggest that the Family Advisory Council engage leadership to ensure that, that parents are equal partners at the table? And I know this is a very broad question, so maybe Dr. Lael, do you want to take a stab?
I would like to, after we ask Mr. Brown and Ms. Lane, because I think they would be the voice I would take to the table to the administrators. They're very articulate, they're very bright, they're very empowered. I would say, listen to our families. But you, Mr. Brown, excuse me, Ms. Brown, Mr. Lane, tell me what you think. And you'll have to unmute your phone if you did.
Hello?
Yes, hi, Ms. Brown, is that you?
Yes.
Great.
Yes,
I'd love to hear what you have to say.
Okay. Can you repeat the question? It seemed like it might have been a two-parter.
Sure. Yes, so it said that we have often encountered significant difficulty ensuring that parents are heard by professionals. So what do you suggest a family advisory council can do to engage leadership in order to ensure that parents are indeed equal partners and their voices are heard?
I believe that the advisory board having a better connection, because there are nurses and maybe doctors on the advisory board, they would be able to tell a parent how to approach a certain situation and how to articulate themselves in a way that the doctor knows that, you know, they are a parent who is concerned and who is involved and who cares, so that the parent, well, so that the doctor is refocused. You know what I mean? So that the doctor knows that this parent is involved and this parent cares and this parent wants to be involved and this parent wants to know all that they can know and help in any way that they can. If that answers the question.
Yeah, this is Christina Pelaez. What I would say is that I encountered that here, and what it works for me is like Mrs. Brown said, to have you know, other members of the staff, like I said, the specialists, the hospital, and the staff to be involved, and then just hear Mr. Lane talking at the grand rounds, that make a huge impact. So you have to, to have them out there and let them speak for themselves. That's what it helps the most.
Great. Thank you so much, Dr. Pelaez. Tim, do you have anything you'd like to add, or has everything been pretty much covered by those answers? Okay. Well, thank you, everybody. Unfortunately, we are running out of time, so I want to thank everybody so much for participating, our faculty members and our moderator, and of course our audience. We really appreciate your time. This webinar will be recorded, and the slides and the recording, as well as the question and answer session, will be archived about a week from today on our National Center for Medical Home Implementation website. Additionally, you will all receive an email after this webinar shortly. We will be asking you to complete an evaluation, which will only take a few minutes of your time, and we would greatly appreciate it if we could receive your feedback. So this has been the third and last installment of our 2014 webinar series, and on behalf of the National Center for Medical Home Implementation, I want to thank you all for your participation, and we look forward to seeing you again next year. So thank you very much, and have a great rest of your day, everybody.